Okay, great. Sorry about that, just technical difficulties here. So you have the objectives for the talk today. I just wanted to say I have no conflicts of interest. So the World Health Organization divides pulmonary hypertension into a number of different classifications, 5 to be specific. And we're going to talk about one of them, a little bit about a second, I guess. We're not going to talk about PPHN. We do have patients, obviously, that we all share that have congenital acquired left heart inflow and outflow tract obstruction and cardiomyopathy, but that's going to be beyond the scope of today's talk. What we're going to do is talk about developmental lung diseases, specifically bronchopulmonary dysplasia, and talk about the pH that can develop due to the chronic lung disease and hypoxemia. So for an introduction, you all know that in neonatology you've made great strides in recent decades to minimize development of bronchopulmonary dysplasia through use of antenatal steroids, surfactant, exogenous surfactant, and gentler forms of mechanical and non-invasive ventilation. Specifically here, you guys have championed the use of bubble CPAP, which has resulted in significant decrease in incidence of BPD early. And I will talk about this as we go further in the hour. Still, nationally, BPD is the most common complication of premature birth. And in some reports, still up about 2/3 of the population born at less than 28, 29 weeks gestational age. The incidences of pulmonary hypertension, however, is unknown since there's really no consensus regarding the best screening strategy. I needed to review the various stages of alveolar development. The embryonic and pseudoglandular certainly in the first 16 weeks, but we're going to focus mostly on the canalicular and the saccular stages of lung development. And so with the old BPD, with the postnatal exposures beyond in the late saccular stage and the alveolar stage of development, the chronic ventilator-induced lung injuries, oxidative stress are well known to you. And those resulted in structural injury. But now that you have refined the delivery of your modes of ventilatory support, and we're now able to have other disciplines that assist us in allowing children at younger gestational ages to survive, what we're dealing with is much more that of a developmental arrest or delay in pulmonary development. So what we're talking about primarily is the late canalicular and early saccular phases of development. So in the normal canalicular phase is the formation of terminal branches of the bronchial tree. And you start out with a double capillary layer and primary septae, and then what you do is extends into secondary septum, growing into the airspace, resulting in invagination here and greater surface area. And alveolar type 2 cells are progenitor for the type 1, and then the type 2 differentiation gives the onset of surfactant production. The secondary septation occurs in conjunction with fibroblasts, endothelial cells, etc., and that eventually a mature septum with capillary fusion and thinning of the interstitium. The saccular phase then also, these are not separate obviously, but the saccular phase is that where alveolar cells stimulate endothelial growth through vascular endothelial growth factor. There's outgrowth of the vessels and angiogenesis along with the development of the alveoli, and as we said, thinning of the mesenchyme. So that this is just a scanning electron microscope of the lung parenchyma from an alveolar septum and looking at the scanning EM at a higher power there. So this is a very intimate interface in the interalveolar walls. In the normal lung histopathology, I'm sure you're all familiar with, which is the terminal bronchial, respiratory bronchial, sac, and then alveoli, with the normal alveoli at a high power level having a huge surface area compared to the vasculature and the interstitium. So you're well aware, I'm not going to spend too much time, but in the initial discussion by Northway in the early phases of description of the old bronchopulmonary dysplasia, he was talking about children born at 34 weeks gestation or 2,200 grams, and still had a very high mortality. But the pathology has improved with the decreased as the ability to manage this has improved. It still resulted in significant scarring with the old BPD, alveolar collapse, the vascular hypertensive changes in some instances as well. And so on a histophotomicrograph at low power, it's really hard to differentiate this lung tissue from tissues of, say, liver or other organs. Whereas at the high power, you have this acellular eosinophilic hyaline membrane that develops. There's also a plethora of cells in the interstitium, resulting in interstitial fibrosis, and then ultimately development of severe fibrosis adjacent to emphysematous changes and overdistension. And we're going to see some radiography and some other cartoons later about what this represents and the heterogeneity of lung damage later in the new BPD is also possible to have changes that are consistent with this type of photohistomicrograph. So in young children, there's a decreased BPD incidence for those children over 28 weeks, but the incidence is unchanged for very low birth weight infants, that is, those less than 1,000 kilos. And although 28 weeks, the new BPD being different clinical, radiographic, and pathologic characteristics that primarily reflect disruption of the lung development, but not as much parenchymal fibrosis. And the long-term sequelae as well may not be the same. The parenchymal pathophysiology of the old BPD is injury to the arborizing lung due to the volutrauma, barotrauma, atellect trauma, and the biotrauma, primarily that being by toxicity by reactive oxygen species with infection and inflammation. The reactive oxygen species result in a disturbance of growth factor signaling, extracellular matrix assembly, vascular development, and cellular proliferation to apoptosis. In the new BPD, as I know that you're aware, but just to kind of run through some of the overlap between chronic lung disease, or the BPD, and pulmonary hypertension, the survival is significantly improved for those children in previously unattainable gestational age is now within the 24 to 26 weeks gestational age, greater than 50%. And with the BPD risk related to birth weight, but only two-thirds of the patients, or two-thirds of the patients rather, have only mild distress at birth and require minimal initial ventilatory support with relatively low O2 levels, supplemental O2 levels. The alveolar simplification and impaired vascular growth, however, manifests as other features of growth go on. The physiologic effects are that due to the decreased alveolar capillary surface area, impairment of gas exchange, increased exercise intolerance, development of pulmonary hypertension, and obviously poor tolerance for any respiratory infections. And the cartoon of this associated with the photohistomicrograph is that of fewer alveolar attachments, airway collapse and a reduced airway caliber, milder but nevertheless still present epithelial lesions, peribronchial inflammation and fibrosis, although again milder, dysmorphic pulmonary microvascular network here and here in the photohistomicrograph, and then also fewer and larger alveoli, as pointed out here, as well as in the cartoon. So these are the primary features of the new BPD. So the development of pulmonary hypertension, we want to get a little bit what the definition is, and that's a mean pulmonary artery pressure, 25 millimeters of mercury at rest, or 30 millimeters of mercury with exercise or crying or increased activity. The estimated systolic PAP is 40, done by echo, but it doesn't take into account, these definitions don't necessarily take into account the transitional physiology experienced by many of our neonates. It's mostly that those numbers are mostly used in the older pediatric patients. And the ATS guidelines suggest that a mean PAP greater than 25 millimeters of mercury in children over 3 months at sea level is the definition, primary definition of pH. And the pulmonary artery wedge pressure less than 15 with 2 Woods units or more being pulmonary hypertension. So the pathogenesis of this is that of oxidant and oxidant stress and hyperoxia. And there's a transition, of course, from the low oxygen tension fetal environment to a relative extrauterine hyperoxia. This impedes an epithelial mesenchymal interaction. I'm trying to look at this from the parenchymal standpoint initially, then we'll talk about the vascular standpoint in a moment. But there's endothelial and alveolar type 2 cells that are susceptible to this reactive oxygen species induced injury. And so inflammation along with this occurs either whether it be prenatal from chorioamnionitis or postnatal from hyperoxia, and associated with higher neutrophil counts, activated macrophages, oxidant that's inactivated or oxidant inactivated alpha-1 antitrypsin defenses, pro-inflammatory cytokines, macrophage release of tumor necrosis factor and transforming growth TGF-beta, and activated neutrophil release of elastase and collagenase, which will be partially resulting in some of the emphysematous changes that would occur later. So the longitudinal imaging to the left is an old slide from Steve Abman, where the initial film on the left ultimately resulted with the severe cystic changes noted on the right. The right panel is that of a control, then a mild, and then a more significant BPD patient, but all of these are at about 3.5 years. And I draw attention to the severe BPD in the lower right corner at 3.5 years being the result that we have a huge heterogeneity in lung architecture here, which really complicates some of what we try to achieve for lung growth and preservation of lung function. So we'll talk about going between the NICU and that 3.5-year time point, but there can be significant residual heterogeneous lung scarring and damaging. So the vascular disease in BPD, with the new BPD, there are less severe acute symptoms, but the chronic changes, those of dysmorphic vascular growth, the impaired alveolarization, and the pulmonary vascular disease contributes to late BPD mortality and morbidity. The clinicians underestimate the impact on poor BPD outcomes of this pulmonary vascular disease, I think. And the PH then reflects a more severe form of the pulmonary vascular disease seen earlier in neonatal life. The morbidity and late mortality of PH in the new BPD remains high, and up to 48% mortality or 50% mortalities 2 years after the PH diagnosis in some series. So the disruption of this vascular development is many factors, but most articles that I reviewed look primarily or in a major component of this being from vascular endothelial growth factor that normally is expressed in distal airway epithelial cells and acts as an endothelial cell mitogen. It stimulates the temporal and spatial development of alveolar capillaries. The VEGF is decreased by O2 toxicity, and it may result in endothelial cell death or apoptosis, and decreased VEGF protein and mRNA in bronchopulmonary dysplasia is seen especially on biopsy studies or postmortem studies in areas with alveolar septal thickening. Changes in alveolar epithelial cell phenotype also occur to the chronic injury and repair cycle. So early pulmonary vascular disease precedes BPD, however, and is associated with PH development. There's echo evidence of PH in significant number of preterms at 36 weeks post-menstrual age. And this is strongly associated with BPD and duration of oxygen use. The PH is prevalent in severe BPD as well as other milder forms of BPD, but it's not solely related to the lung severity, the BPD severity itself. And we'll talk in the coming slides that at day of life 7, the pulmonary hypertension signs are common and associated with the risk for both BPD and late pulmonary hypertension development. The absence of PH at day of life 7 is associated with a lower risk for late PH. An hypothesis then that I would put forward is that early pulmonary vascular disease really precedes some of the development of BPD and strongly is associated with development of late PH. The survival effects of PH diagnosis, that of PH and cor pulmonale, result from extreme forms of the pulmonary vascular disease are recognized factors with high mortality. The BPD infants diagnosed with PH at more than 2 months of age have a poor survival, less than 2/3 at 6 months, and only half survive at 2 years post-diagnosis. The natural history and role of the PH in BPD as an early risk factor is unclear, however, for the late onset and for BPD remains unclear. And the absence of data-derived PH definition and lack of the non-invasive, reliable, quantifiable assessments has impeded studies of this disease. And you would ask, well, we have echo. Isn't this non-invasive, reliable, and quantifiable? But I would vouchsafe to say that you'll not believe it's as helpful or not as strictly defining for us as we might think. So using a broad-based echo definition of PH, at day of life 7 here, with all subjects, a 42% incidence of PH was seen in day of life 7, but only 14% at 30 by 36 weeks post-menstrual age, with the highest incidence being 29% in severe BPD patients. The various graphs, this is from the black boxes. The others are from alternate pH, using alternate pH criteria. But even those with none, mild, or moderate bronchopulmonary dysplasia, about a 9 to 10% incidence of PH is defined by echo. Using stricter pH criteria, echo criteria, you'll have a dramatically reduced pH incidence. And if you use the two major predictors here, although qualitative, are septal wall flattening on day 7 of life and right ventricular dilation on day 7 of life. This is associated most strongly with pulmonary hypertension later. It's also associated with prolonged positive pressure ventilation and need for supplemental oxygen exposure. But even subtle early pulmonary vascular disease signs on echo at day life 7 is a risk for both BPD as well as development of PH, of course. So echocardiography is the most widely used to assess pulmonary pressures and right ventricular function. It is accessible, non-invasive, and portable, but it is also different in that pulmonary vascular tone fluctuates many issues that we see commonly in the NICU with agitation or discomfort, whether the patient's being sedated or has significant analgesia on board. There are mechanical ventilatory effects, the child's degree of acidosis or alkalosis, as well as hyperoxia or hypoxia, and various medications affect the accuracy of the echocardiographic measurement. But there are 3 categories of data that we collect: the qualitative assessment of elevated right afterload, the pulmonary hemodynamics and right ventricular systolic pressure by Doppler tricuspid pulmonary flow, and the qualitative assessment of right ventricular morphology and function. So the primary modality of that is of a TR jet is used to estimate peak systolic pulmonary artery pressure. This is the most objective measure of pH, but it really requires very reproducible holosystolic envelopes to be able to judge. And it's a long gone to and probably very helpful measure for patients who have right ventricular systolic pressures greater than 35 millimeters with the tricuspid jet velocity greater than 3 meters per second. But these are adult criteria. In pediatrics, often we'll talk about this as being more than 50% of systemic pressures. But the TR jet velocity is really only measurable and routinely or able to be found in less than 2/3 of infants. So it's less helpful than one might think because of several of the issues mentioned previously. So there are other measures. TAPSE, the tricuspid annular plane systolic excursion, is an index of right ventricular systolic function, where the tricuspid annulus excursion, a distance on a longitudinal plane using ebb mode tracing and using an apical 4-chamber view. It's a line of interrogation here, aligned along the apex going through the lateral aspect of the tricuspid annulus. And this from diastole to systole. And what this is reproducible and relatively simple to measure, but it too is dependent on several factors, including the angle, ability to get a good angle, as well as being preload dependent. It does not evaluate apical right ventricular systolic function, however. There's a very different pathology of right ventricular failure and pulmonary hypertension. The right ventricular muscle, of course, is only about a sixth that of the left ventricle. The left ventricular volume has to be pumped, or the right ventricular volume is the same as the left ventricular volume, and it does so with 25% of the work. And the reason is in part the orientation of the right ventricular muscle, with superficial muscle being muscle fibers being circumferential and more longitudinal in those that is contiguous with the interventricular septum. And the peristaltic right ventricular contraction goes in almost a ringing motion from inlet to infundibulum. And there's a triangular pressure volume wave that is created in the right ventricle, whereas it's square in the left ventricle. And so the left ventricle free wall and septum also has oblique fibers that twist and shorten and has an ejection fraction greater than the right ventricle. So the right ventricle has obviously less pumping capacity and is more susceptible to failure. We talk also about another measure of left ventricular eccentricity index is a proposed pH marker in BPD. And this is a ratio of the perpendicular parallel left ventricular diameters compared to the septum. So normally this would be a rounded left ventricular, but then with septal flattening, that quantifies the septal distortion by increased right ventricular overload from high pulmonary pressures. And the short axis view at the left mid-papillary muscle level has an elevated eccentricity index because of septal flattening. But the pathology of this right ventricular failure, this flow chart here in the right panel, really is just to go ahead and show that when you get increased right ventricular pressure load with the diastolic dysfunction and systolic dysfunction, it sets up an ability with the diastolic hypertension, the ventricular, because of the diastolic ventricular interdependence, it can affect reducing the left ventricular filling and output. It can reduce left ventricular assistance to the right ventricular ejection and sets up a very vicious cycle here. And the qualitative echo findings are that of the right atrial enlargement, ventricular hypertrophy, right ventricular dilation, and pulmonary artery dilation, as well as the interventricular septal flattening that was seen in the cartoon in the prior slide. This appears to be more sensitive, as we talked about before, but it's not quantitative. And I really can't tell you the severity of pulmonary hypertension that may be seen on hemodynamically. And so if you begin here at the blue arrow, if pulmonary hypertension is diagnosed on echo at 30 weeks gestational age, corrected gestational age, if the patient has symptoms of congestive failure as seen here with right ventricular dilation on echo, the first thing one would do, as you all do, is initiate diuretic therapy. If you don't find this, you just do echo surveillance every 7 to 14 days. And then if worsening echo features or right ventricular dilation occur, worsening symptoms of pulmonary edema or respiratory failure occur, then you would also go over to initiate diuretic therapy. And if these features don't worsen, but you still have features on the pre-discharge echo, we're going to go to the next panel here and see that here you would find that you just suggested outpatient cardiology referral, but with the diuretics, you would repeat the echo features of the pulmonary hypertension. If their symptoms are improved, you continue to do diuretic therapy, the echo surveillance, and this is where we get involved often in the NICU, and it can, progress on through being able to discontinue diuretics as the patient grows, observation, and the patient ultimately discharged home. But if the echo features or the clinical symptoms are not improved, then one needs to consider use of pulmonary vasodilator therapy. So initiating PH therapies. Ideally, cardiac catheterization should be considered prior to initiating long-term therapies, not INO, and in some cases not sildenafil, although there is an argument to be made for doing it even prior to initiating sildenafil therapy. So the initial nitric oxide level started at 20 for symptomatic or severe pulmonary hypertension. Transitioning to add sildenafil is feasible, starting at 0.5 milligram per kilo Q8 hours and advancing to 2 milligrams per kilo Q6 hours. If one then is unable to wean nitric oxide consideration be added for consideration for adding endothelial receptor antagonist or a prostacyclin analog. Again, having a cardiac cath data, I think, would be absolutely required in that case, or serial, and then using serial echocardiography to monitor response. In the NO, just briefly, I know you're all familiar with it. It stimulates vascular smooth muscle guanylate cyclase activity by increasing cGMP and resulting in vascular smooth muscle relaxation. The difficulties are, of course, that it requires continuous inhalation, such as in a NICU, has a very short half-life, and is not able to be used by us for when we assume the responsibility for the patient's post-discharge. It's also very helpful during catheterization to do with and without, but the logistics of continuous treatment obviously prevents longer-term management, not to mention the extraordinary expense of long-term use of this therapy. And so the addition of PDE5 inhibitors, the primary being sildenafil, is a common first-line therapy used either in place of or in conjunction with if you're unable to wean INO. It's PDE5 is highly expressed in the lung, also uses cyclic GMP as a substrate, and has a binding domain, which is the primary regulator affecting catabolic activity of the cyclic GMP. It's a critical controller of nitric oxide mediated vasodilation and is widely used in adult and pediatric PH, although the data, although increasingly robust, are still more limited in BPD-associated pulmonary hypertension than other forms. So the prostacyclin therapies, prostaglandin I1, I2 is a arachidonic acid metabolite that's endogenous to the vascular endothelium. It binds to a receptor inositol phosphate, stimulating cyclic AMP production, and therefore smooth muscle relaxation via decreasing intracellular calcium levels. Epoprostenol had been used. I think we weaned our last patient who had been requiring this long-term about 3 to 4 years ago. It has an extraordinarily short half-life, requires continuous infusion by a central catheter, and that the solution needs to be continuously refrigerated, which is very problematic long-term. So iloprost is also a prostacyclin that's been found to be very helpful with a longer, but still only a 20 to 30-minute half-life. It can be done inhaled and has fewer side effects. With treprostinil being longer acting, it can be either by subcutaneous injection with the bioavailability similar to that of IV preparation, or it can be by inhalation every 4 to 6 hours. And this has become more commonly used by us and other pediatric centers, as have endothelin-1 receptor antagonists. And so ET1 is a potent vasoconstrictor that's produced in endothelial cells in response to hypoxia. It promotes endothelial cell dysfunction, smooth muscle proliferation, remodeling, inflammation, and fibrosis. The primary agent we use is bosentan, but ambrisentan is also used in some institutions, bosentan being an orally active, non-selective ETA and ETB receptor antagonist, with ambrisentan being a more recent agent, but less pediatric experience in most centers. There are other emerging PH therapies, soluble guanylate cyclase stimulators, L-citrulline, rho kinase inhibitors, and PPAR gamma agonists. So the guanylate cyclase stimulators are riociguat and sinosiguat, which also increase cyclic GMP production, which results in vasodilation. They were approved earlier by the FDA for adult use, and they're used, I think, in somewhat as a third line therapy, mostly in pediatrics, especially in NICU settings. I think Dr. Baluz and the rest of our team has used it in a handful of patients as third line therapy. We have a number of adolescents, however, have derived incredible benefit from these agents. L-citrulline, which is an L-arginine precursor used by NOS in production of nitric oxide, and fasudil, a rho kinase inhibitor, blocking phosphorylation of myosin light chain in vascular smooth muscle cells. And rosiglitone, the PPAR gamma antagonist, regulates smooth muscle proliferation and vasodilation through Rho kinase. So again, once the echo-described pH is present, this is really not to go through the flow chart, but really just to go ahead and talk about the fact that circling back in, based on the degree of initial pulmonary hypertension observed here, if over 2/3 with septal flattening, one's going to go ahead almost invariably and get to cardiac catheterization. And then if milder, do the mechanical things for optimizing gas exchange, targeting saturations in mid-90s, diagnostic evaluation, including involving comorbidities, but echo measurement, serial echo measurement, and measurement of BNP or NT-proBNP if the pH fails to improve echocardiographically. So serial measurements clearly are recommended. So comparing the primary outcome with patients the in-hospital outcomes are huge in terms of mortality before discharge if pulmonary hypertension, rather than just in addition to BPD or BPD alone. The p-values for mortality before discharge, duration of invasive ventilator days, non-invasive vent days, a length of hospital stay, and percent of patients being discharged on home oxygen, all is very significant if pH is an ongoing diagnosis beyond the 36 weeks post-menstrual age. So there's changing care issues during the progression of BPD from early, where we focus primarily on prevention through delivery room practices, surfactant delivery, non-invasive CPAP, high-flow nasal cannula, et cetera, early on, to after 7 to 10 days, utilizing other methods of oxygen use and ventilation, steroids, et cetera, to modulate this evolving situation. But ultimately, with established, what we have left really established BPD is still manipulating ventilation and oxygen use. But we need to go ahead and talk about the fact that these are two different scenarios here. So in terms of managing, I wanted to discuss a little bit about the impact from the pulmonary perspective about the heterogeneity of the lung disease once patients have severe BPD that is defined, shows huge implications for subsequent management. And so and for ventilatory strategies. And there are marked variability in time constants that I think would not be hard to convince you of if you talk about time constants for lungs that are very dense like this versus hyperinflated or air trapping areas with the mixed airways and parenchymal diseases, decreased surface area of the hypoplasia, and also with the severe BPD, tracheobronchomalacia, airway secretions, probably some degree of chronic microaspiration, if not overt episodes of overt aspiration, and the development of pulmonary hypertension. So we have to take a somewhat different approach, I think, to mechanical ventilatory support, as there's this evolution of BPD, in part triggered by this early identified pH and then subsequently later identified pH. And the heterogeneity of the lung disease and established BPD is largely due to the role of variable time constants. So when you have low tidal volumes, you are able to ventilate adequately areas that have high compliance and low resistance, but there's adverse effects that come from that. You're ventilating these areas, obviously, and not this, with low tidal volumes and short inspiratory times. What you do wind up with is worse gas distribution, increased dead space ventilation, higher CO2 levels, requirement for higher supplemental oxygen requirement, and progressive atelectasis and regional overdistension. And so basically what you wind up with is a two-compartment model based on patient position often, or prior scarring that may have occurred. So the way that you would get this is by, recruited then is by increasing PEEP and prone positioning, and for this using smaller tidal volumes. so you don't have over distension. So looking at a change in strategy from early to well-established BPD is that you don't want to go ahead and have low tidal volume and short inspiratory times. What you want to do is aim towards higher tidal volume and longer inspiratory times, which improves the gas distribution to areas that have different degrees of compliance and resistance, with improved gas distribution, lower CO2 levels, lower requirement for FiO2, and less atelectasis. So there's this early ventilatory strategy, again, that relies on the low tidal volumes for 4 to 6 milliliters per kilo, with short inspiratory times, and PEEP being increased sequentially for lung recruitment without overdistension, and achieving a lower FiO2. Whereas in the late, in the established, patients, I believe, do better with larger tidal volumes, 10 to 12 mils per kilo, longer inspiratory times, and airway obstruction has slower rates, which allow for better emptying with longer expiratory times as well, because of the lower rate. And there's a complex role for PEEP due to the dynamic airway collapse. So this is a more complex issue in the later BPD. Again, the goals for the gas exchange are to adjust to lower FiO2 to target adequate saturations and allow for permissive hypercapnia. But I think where we have discussion points are that when we get referred and we have a dialogue with you, the issue is one that this is not a care path or a pathway per se, that each patient is a somewhat different need. The physiology needs to be taken more on a more individualized basis, although guidelines can certainly be helpful, I think. And so we have to come to an agreement as what is stable in chronically ventilated infants. And and when does one transition from the strategies that have been so helpful in NICUs for the bubble CPAP and for the permissive hypercapnia to later on, where there's more well-established BPD? The strategy needs to be managed in part because we have to overcome and support these children. So the tolerance of therapies during care and handling with minimal episodes of desaturation and distress. And I think it's evident, we discuss on a not infrequent basis the episodes where a patient is having these blue cyanotic episodes with huge respiratory distress requiring discontinuation of ventilatory support, including non-invasive ventilatory support and vigorous bagging, because this is what's occurring, and these episodes may well represent not bronchospasm, but may well represent pulmonary hypertensive crises. So still, though, we need to have less reliance on blood gas tensions for PCO2. This is not necessary. It's not necessary, obviously, to be able to maintain lower CO2s. What we do want to do is have consistent growth, both weight and length, and weaning of FiO2 and not tidal volume or pressures, so that we can go ahead and provide, again, a discussion point, what is stable in these chronically ventilated infants. So the questions then for transition to a chronic respiratory care for these infants is when to transition from lung protective strategy to chronic support strategy. The pulmonary hypertension obviously is a component, the evolving pulmonary hypertension is obviously a component of that. And what is stable disease? Is this actually bronchospasm? Is this actually airway? Or is this in fact a vasculopathy that is manifesting episodically based on degree of sedation, ventilatory support, et cetera? And when to commit to chronic ventilation and actually use a tracheostomy or invasive ventilatory support for supportive care. I'm not advocating the tracheostomy, but I think we need to talk about what are ways that we can go ahead and at an earlier time point have discussions with families, whether if we feel that this is the direction in which a patient is going because they're failing to grow, they're having recurrent cyanotic episodes with minimal stimulation, we have to entertain the possibility that a lot of this may not have a pulmonary parenchymal or an airway component, but it may very well be much more of a manifestation of a pulmonary vascular component of that child's disease at that time. And the frequent pitfalls in the care that as we make this transition from NICU to pulmonary service to going home that, you know, these chronic patients in an ICU take precedence. So, I mean, the acute patients take precedent over these chronic patients in ICU settings. They have a very difference in their pace of illness and their response to therapy. And both of our services have high staff turnover, which leads for opportunities to inconsistencies in care. The consistent communication between attendings, nurses, RTs, consultants, providers, and the family is complex. And I would urge a discussion of at earlier time points or early time point that, you know, when we find that we are not having a child who's responding well to some of these ventilatory strategies used earlier, such as diuretics, such as steroid bursts, and we're noticing the evolution of episodes of this, what I would say suggest a pulmonary vasculopathy and evidence of possible evolving pulmonary hypertension, that the discussion being is that we need to probably look at changing from a strictly pulmonary strategy to one more of a cardiopulmonary strategy, entertaining pH as a component of that. And obviously this requires the need for interdisciplinary approaches. So I hope I've talked about the birth in the canalicular early saccular stage as that of a disrupted lung development and impaired septation, the pro-inflammatory response that initially is used with steroid, mechanical ventilation, etc., the reduced number of alveoli allowing for lung growth to manifest and improve that. The consequences are huge for inappropriate early high pressure, high oxygen level mechanical therapy, and also the strategies for weaning as the patient continues to develop for decreasing oxygen delivery, level of oxygen. The alveolar stage development cannot induce catch-up growth. It leads to limitations of lung function. It's too late by the alveolar stage development. The die has already been cast in large part, I think. There's a serious distortion of pulmonary vascular development that I hope I've been able to elucidate somewhat, and that there's this double pathology, both of this decreased lung surface area and a decreased capillary network with a much higher risk of pulmonary hypertension development and up to 25% of children with bronchopulmonary dysplasia. And so the multifactorial contributions to pH are the decreased growth, the abnormal function with high vascular tone, altered vasoreactivity, and impaired metabolic functions, abnormal structure, resulting in decreased surface area for exchange. So the need for prolonged therapy, the altered redistribution of blood flow in response to infection, and changes in heterogeneity in lung development, the evolving exercise intolerance or activity intolerance or therapy tolerance, and then also echocardiographic evidence of evolving pulmonary hypertension certainly need to be considered here. So in conclusion, the factors that contribute to development of severe BPD and modulate long-term outcomes are incompletely understood. Ventilator goals and strategies for chronic care of vent-dependent patients are really strikingly different than current approach to acute respiratory failure. An improvement in the long-term outcomes require greater and earlier integration of these interdisciplinary teams that link the inpatient with the ultimate ambulatory care. And with that, hopefully we have some time for a couple of questions and a little bit of discussion. Thanks for your attention.
Thank you, Dr. Carl, for this great overview and kind of changes in management over time in the decades, as well as over the chronological age of our patients. It was wonderful to hear from your standpoint and the trajectory that we need to go as a multidisciplinary care team for these babies. We have a few questions coming in, and the first one is asking if you could comment on your experience with increased subdural spaces or SVC syndrome in patients who are hitting peak pressures greater than 30 that have established BPD.
Yeah, I mean, that's, again, I think that's incredibly important. I think is, preload is huge, as I said, by some of the echocardiographic measurements, and the accuracy of those measurements non-invasively, depending on the level of activity or the neuromuscular activity of the patient at the time, as well as positioning. I think that's huge. That clearly is a very critical pressure, I think, and I think if, I think this is at the cusp of probably looking at questioning whether echocardiographic measurement alone is sufficient or one needs to think of catheterization.
Thank you, Dr. Carl. One of the next groups of questions is there a time period in which, in terms of corrected gestational age, we should be considering transitioning from acute management to chronic management of patients with evolving or established BPD?
Yeah, I think it's very dependent upon the patient, the comfort but I mean, I think, I don't know that a particular gestational age. I think that when we're very happy, and Rule of Balluz, who I think everybody knows and is aware of, is very involved in the program. This is not a pulmonary program. This is a program that is a joint program between cardiology and pulmonary medicine. I think once patients are not acting in the fashion, I mean, you're talking about doing 2 and 3 DART protocols, where you're having growth failure, where you're unable to be weaning, having sequential weaning moves, and you're having episodes where a patient needs reintubation or has failure. Clearly there are times when somebody has, that a child would have a superimposed infection, gastrointestinal intolerance or feedings, etc. But I think, there's a constellation of issues there in the mid-range, and I would say that I think it's a little bit hard to put exactly a week post-menstrual age on that. Some patients early on seem to do very well, and I'm astounded when I have a patient come into that I've not dealt with in the NICU, come in and they're a 24-weeker and they've done well and they have, no oxygen, and I'm seeing them at 9 to 12 months of age, and they're doing wonderfully. That patient is not going to be the patient that we're probably talking about at 36 or 40 weeks post-menstrual age. That maybe is a 24-weeker. So yeah, I mean, I think it's hard to say. I think it's really more dependent upon the needs of an individual patient, and whether you who are the masters of the neonatal management, when you're feeling that we're not being successful in terms of moving forward as you would expect the normal growth during that late saccular phase to progress, would be a time that we'd want to be considering, involving a more interdisciplinary approach.
Thank you for that. Along the similar lines, clearly a discussion to have in conjunction between pulmonology and cardiology, but is there ever patients that you would select for invasive measurements such as cath, and who would you select for that intervention or diagnostic intervention?
Yeah, so I mean, I think basically what Dr. Balluz and our team has kind of come to a belief that it is probably better if we're using sildenafil at whatever stage of dose and not achieving the desired effect of progression, and we're plateauing in terms of growth or ability to wean subsequently, as we'd expect further alveolarization to occur, and we're getting the intolerance to or the lack of growth, the intolerance to handling, in consideration for a second vasoactive agent, I think really mandates catheterization, so we can actually quantify rather than disqualify the patient as having this. And then one can then go back and utilize 100% FiO2, nitric oxide to actually quantify the hemodynamics at that time, which gives us a much better handle for a therapeutic strategy from that point to the time of discharge, I think.
Thank you. There is a question that relates to nutrition. So we all know that the nutrition is important in helping to some degree prevent BPD, but also to help transition our BPD kids off their long-term respiratory management. So there is a question about whether what your thoughts may be about using transpyloric feeds as part of a lung protective management, and what experience, in a slightly different way, what experience have you had in obtaining and treating trach aspirates that are gotten when kids decompensate?
So the first part of the question is, what about transpyloric feedings? I mean, obviously, parents and the rest of us are reluctant to place gastrostomy tubes. It's not something which is easily, those are difficult discussions to have with parents. If somebody is, tolerating NG feeds and is not having huge increased work of breathing and is progressing well, I see no reason why that has to be a transpyloric feeding. I think when I've had discussions with many of you about the, moving to a transpyloric feeding, is when you've hit a seeming plateau or a huge pause, where you've needed to give additional courses of steroids, when the work of breathing is huge, including somebody who's, not progressing and weaning of non-invasive support measures and is plateaued or is requiring high levels of oxygen and has, significant tachypnea. I mean, I think those patients are working really hard to breathe, and I think that it's more difficult, and I think a more protective strategy would be to have transpyloric feedings. That is, I would leave that at everybody's discretion in the neonatology program, whether that is through a nasoduodenal or GJ, however you want to do that. But I mean, I think being protective of the airway. The second is the question, or the second comment was about use of tracheal aspirates. I think, I presume that means when you are getting to worry about tracheitis that occur if somebody's had an indwelling endotracheal tube for a while. And, I think tracheal aspirates may be of significant help. Unfortunately, if the question was that and related to feedings and in terms of trying to define aspiration, our pathology department is no longer doing lipid-laden macrophage indexes. So because they did not find them to be very consistent, that has been dropped. So looking for lipid in the typical alveolar macrophages is not an option at the present time. In terms of looking for organisms, I think it's less helpful to have cultures from an indwelling oral endotracheal tube, say, that's been there for 3 weeks or such, because there's so much colonization in the bronchial space, and I think you're not able to, find where exactly you're getting this this sample from. If one can be directed, we're happy if the patient is stable enough to try to help you, as many times people have asked. We have atelectasis this area. We want to see if there's, some type of mucus plugging or some type of, atelectasis. We're having a hard time using all the airway clearance methods and the respiratory therapy methods to do lobar recruitment, or then can we lavage to try to see if we can try to help ventilate a particular lobe. At that point, I would say utilizing, again, with the caveat being the patient's stability, utilizing a bronchoscopic approach might be a way to go. So you can get a much more pristine sample, not through a tube that's been indwelling for weeks.
Thank you for that, Dr. Carl. There are a few people that have a question that are related. So they're asking frequently when there is evidence of pulmonary hypertension on an echo at 36 weeks. Sometimes the cardiology and PH team is hesitant to start pulmonary vasodilator treatment as they worry about VQ mismatch and worsening pulmonary edema. The neonatology team is concerned about not treating. What would you suggest be done or ways to work with your multidisciplinary team?
Yeah, I mean, my own experience is that there's really been comparatively little. I mean, as long as we're collaborating, there's been relatively little, kind of dissent in opinion about the need for that. I think the issue may come, there's obviously reluctance if there's still a shunt that is there in using vasoactive agents to lower pulmonary artery pressures and lower pulmonary pressures, because that can really exacerbate and cause a lot, accentuate the left to right shunt. And, that be through PFO or, ongoing ductus. Those things can, certainly I know Dr. Beluz and I have talked about this in a number of patients that we probably have shared with you, where that can lead to more problem. And I think then, there may be more reluctance to, if the patient is growing, to allow that growth to occur so we can get really objective quantifying data by cath, rather than just going ahead and doing something which may have the opportunity for actually causing more problem. I don't know. I mean, if you change the perfusion that much, it's obviously not changing the ventilation, it's perfusion you're changing. So I think that I've seen, not disagreement, but I've seen, perhaps that's not been focused on enough in the discussion, that it really is more, in my experience, more when there's a concurrent shunt.
Thank you. There's a question on what should the goal oxygen saturation targets for chronic lung disease patients that don't have pulmonary hypertension be, and if they are identified as having pulmonary hypertension, would their saturation targets change?
Yeah, I think if you have evidence of vasoreactivity, we certainly are aiming for mid-90s. There's a 3% variation in accuracy, at least, of oximetry. So I think if we leave somebody at 90, it could be 87. And if we're sitting with our standard, I think SATs that we'd have for an older child on the floor, that's probably not adequate. So targeting higher saturation. I guess the question is, how fully have we ruled out? Is there a component? This is not, a hard and fast definition of this person has PH or not, that person does not. I think in many cases this is the gray zone where both of our services are actively discussing. What is this? What is this? What are these events? What do they represent? I mean, the child is intolerant of therapies. They're having perhaps some diaphoresis, increased work of breathing. We're unable to be weaning some of the non-invasive ventilatory support measures that we had, or we've got these, recurring episodes where we're backsliding in terms of need for higher levels of support. I think that's the time where this, discussion really, is really apropos.
Thank you. There's a question regarding outcomes in BPD patients with pulmonary hypertension. The question is, we know that BPD infants with PH do worse than those without PH. Are there any RCTs that show that treating at an early versus late stage changes the overall long-term outcome?
Not that I'm aware of. I must confess that I've not looked at that specific question by like a Cochrane review recently. I think the part of my skepticism about that would be that there's such a disagreement in institutions depending on the accuracy of the definition, when this is, onset is, and the manner. I can tell you at the pulmonary hypertension meetings, the pediatric and congenital, the neonatal and pediatric pulmonary hypertension meetings, there's that issue is very much discussed. And I think that these are not, I think the populations are small enough, and unfortunately there's not a national registry that I'm aware of where you can actually pull data and look at that in a prospective manner. And the practices from one program to another are I mean, not strictly neonatology, but the practices of a number of the disciplines is probably, there are enough variations that would be a little bit hard to accomplish at this time.
Thank you. And the last question that we have right now is about chronic management and about what our center or our enterprise likes to use. Could you comment on which home ventilator models, modes, and the range of centers that we are preferentially using when discharging these children home?
Hi, yeah, how many more hours do we have? I think most of our patients now are going on trilogy vents. It is something where you can take it down to CPAP modality. There's a lot of variability. There's been recently a Vosin ventilator. I don't think that's being used much in neonatology at the present time, but this is a very elaborate machine that incorporates a lot of airway clearance devices, as well as being able to deliver. It's kind of an all-in-one package, but I think the trilogy right now, it had been until about maybe 8 or 10 years ago LTV, but trilogy has kind of emerged as the preferential one. In terms of settings, boy, that's very variable. So I wouldn't want to risk a comment on that at this point. What was the other part of that question?
It was just what model and modes,
yeah,
and then the range of settings that they've been going home on.
Yeah, so I'm going to take a pass on the settings. I'm sorry, because it's quite variable. I think you know, the discharge to home. I'll give my personal complaint or perspective. It's all about the service that we get from the durable medical equipment company. And I know there is significant interest in maintaining supplemental oxygen within the Cleveland Clinic system. We have other external vendors that are much more attentive on an ongoing basis to our chronic ventilatory needs once the patients get discharged to home. And unfortunately, when we're stuck with a situation where there's not an attentive durable medical equipment company, the patient, where there's a minor change, winds up being told or has to go to emergency department, and then winds up getting transferred more often than not. And we prefer that not be. And when we have very skilled respiratory therapists and care coordinators in home settings, we can troubleshoot a lot more readily and have replacement equipment or fixing existing equipment done in a much more expedient fashion done by some of our external vendors. So I would say that that's really kind of one of the caveats as to who to choose. I think this is, and it's also something that we would really like to do, and as a part of the discussion, you know, about the patient management in the run-up to discharge, not immediately prior to discharge, because the parents, and oftentimes we have to argue for a particular vendor because it may not happen to be the vendor of choice, but the vendor of choice by, you know, a private insurance is not able to provide an adequate degree of care in the home setting. And that's not a good mix, and it only results in rehospitalizations.
Great. That one last question has snuck in. It may be one of those that's fast, but maybe a little bit longer too. The question is there a value in checking pro-BNP levels?
Yes, I think it is. I would not probably do it before initiating vasodilator therapy, but I think as a trending, I think it is a very helpful measure. Again, It kind of depends on when introduced, but I wouldn't wait too long to use it as a serially measured lab, early on. I don't think it's probably helpful between 7 and 7 day life 7 and several weeks later, but I think after that point it can be very helpful.
Thank you again for your fantastic presentation, Dr. Carl, and we appreciate you taking the time out to join and talk to us about BPD and pulmonary hypertension. And for everyone else that's still on, we look forward to seeing you next month. It's Dr. Mary Donofrio will be presenting on neonatal congenital heart disease in the delivery room. And we hope everyone has a safe rest of January.
Thanks very much.